I'm the lucky person that gets to follow up the Dr. DeJoe lecture, so manage your expectations. I'll do my best. But I was assigned the topic presentation, does my patient have asthma? And thanks to Dr. Pinto for his help. So today, hopefully, we'll go over asthma mimickers and some things you can do to distinguish maybe uncontrolled asthma from another underlying disease that is either in place of asthma or along with asthma. So a good place to start is asthma itself. So definition of chronic inflammatory condition of the airways characterized by variable airflow limitation, bronchial hyperresponsiveness, resulting in what we think of the typical asthma symptoms: shortness of breath, cough, wheezing, chest tightness. Obviously affects a large portion of U.S. adults, over 18 million. And as we know, it's a heterogeneous disease, multiple clinical phenotypes. We've all heard the terms cough variant asthma, occupational asthma, nocturnal asthma, and the like. So diagnosis of asthma, obviously, as I mentioned, variable airflow limitations, so you want to make sure there's actually an obstructive defect that responds to bronchodilators. You can also see the characteristic scooping, which isn't specific to asthma by any means, but on a flow volume loop. And then with the methacholine challenge test in order to rule out asthma to assess the bronchial hyperresponsiveness. While we do have pretty good objective measures, we do know that many physicians diagnose and treat patients empirically for asthma without any objective testing. A large study done in Canada with a database of over 450,000 patients showed that 42% of those patients actually received no testing at all and were just diagnosed with asthma clinically. We also have testing that shows that lack of objective testing can lead to an overdiagnosis of asthma, and another study in Canada showed that 33% of physician-diagnosed asthma patients actually did not have asthma after they underwent pulmonary function testing. This table is from that same study. This is published in JAMA earlier this year. And this is all the patients that underwent face-to-face pulmonologist visits. So you can see that a portion of them did have asthma up there, 28 patients. But a large number of those patients either didn't have any clinical disease at all. A large majority had allergic rhinitis or GERD, and then you had some patients that had less common things: Tracheobronchomalacia, sarcoid, or costochondritis, or the like. So this isn't a comprehensive list, but I like this list because it's kind of a reminder that things that can look like asthma aren't just involved with the lung, but can be cardiac, miscellaneous, or even the upper airway. Yeah.
Just a question about the prior slide.
Yeah.
The one before. So it says objective testing to make diagnosis of asthma. So we're saying that in this study, they were basically saying that they would have to make a diagnosis of asthma based on obstruction on spirometry.
So obstruction on spirometry with a bronchodilator response per the definite criteria, as well as typical clinical symptoms, was what the measure they used.
First of all, we know that's ridiculous because 85% of the asthmatics out there have normal spirometry.
Sure.
Second thing that I really take issue with, very annoying as hell, to see a definition of asthma with an FEV and FVC ratio less than 70%, because if you use that criteria instead of confidence intervals, you're going to be misdiagnosing 30% of the asthmatics. You'll be calling normal because they're above 70% when they're not.
Yes.
That's a tool that's used for COPD management and whatever, that's now been morphed and bastardized into using it for every disease and diagnosis in the world. So I do take issue with that.
Good to know.
I got a question on that.
Yeah.
Dr. Martha, they didn't look at some challenges to help rule out with that. Isn't that increase the sensitivity of kind of what is diagnosed asthma?
Well, here's what the problem is, especially with the topic he's giving right here, with so many different and differential. The question comes up, what percent of the normal population doesn't have asthma as a positive methacholine challenge test? And that's as high as 25 to 30%. So really, when talking about sensitivity and specificity, is all over the map of methacholine. I don't think you can rely on those, and quite honestly, I don't think methacoline's that often anymore, just because of that confusion.
So then you don't feel a negative methacholine convinces you in some way that we shouldn't be going down this asthma path?
Well, here's why I don't, because I published with one of our fellows here, Journal of Asthma, a number of years ago, that we found that when you have patients with negative methacholine challenge tests, they look normal. But they had symptoms suggested asthma, and longitudinal follow-up 3 years later to find out. We had it reviewed by 3 senior staff members in addition to 3 fellows. To find out at that point that like 20% of them had clinically proven asthma. At that point, uninhaled responsive, even though they had a negative test before that, and just all it did was delay their management.
Right. So I guess maybe this isn't the topic, but I'm sort of I wonder if the utility of it when you have that patient that doesn't have those classic asthma symptoms, who comes to you maybe with a cough you don't really understand, or they don't wheeze, or they're short of breath, but that's their only complaint. Then I've been doing methacholine, and maybe you're more of an expert and you tell me that it's not a good thing, if the
Well,
clinical suspicion is not there.
It's one of the only tools we have. I don't think it's a really great tool. But one of the things that the criteria we use on methacholine for positivity is a 20% drop in FEV1 for the concentration of methacholine 8 milligrams or less. That's actually been changed quite a bit in the latest guidelines. Again, we found, published, that in those groups that had negative methacholine challenge tests, that at a concentration, I believe, I can't remember, I think it was an 8 milligram concentration, not positive yet, but if they had was like a 9 or 10, it was actually Emron Khalid that published this, we had like a 9 or 10% change in the FEV1. Again, those are the patients in that group we studied later on that really did have asthma. So maybe the problem is our 20% criteria. We see a test, we do a methacholine, the FEV1 only changes 11 to 12%, we call that a negative test. Chances are it's probably not. But we don't have any better data than that to go on right now, just because nobody's done it.
I think, for me, I kind of fall into the same category as you, and I rely a lot on some of the original ATS documents that look at receiver-operated curves, and I think the two things that I think are really important to take into account with the methacholine challenge is pretest probability and your cutoff. And so to me, if you clinically think the patient has asthma, you shouldn't be doing the test. If you really don't think they have asthma, you shouldn't be doing the test. It's the patient where you really are conflicted, where you're 50-50, that the test is most useful. And I think then if you use a strict cutoff of 4, you say it's above 4, then I can't say they have asthma, but if it's below 4, I know they do. I think that's how I use it. So I think for the fellows, it's really, we don't always talk a lot about statistics, but I think for this test, if you're really careful about your statistics, I think then it can be a really helpful test for the right person for me.
Yeah, the degree of positivity, I think Dan said, is very important also. If they're positive, like a 1 milligram concentration, 0.065 or something like that, well, then you have a much higher likelihood.
Right.
Unfortunately, looking back to older data,
In the military,
it's always fall in that gray zone, so you're never really quite sure.
Yeah, we never would diagnose somebody if they were over 4, and we held very strictly to that because you will have false positive tests if you use a high pressure.
There's a whole new set of guidelines actually that came out just this past summer, and that's confuses the issue even more. Because now they say we should not be using a milligram per milliliter concentration. It's all nebulizer dependent. With brand new use, you should know the specifications of each type of nebulizer to know how many milligrams you're actually delivering to each patient, not a concentration of methacholine, which quite honestly, that was put out by the Europeans. I think that's kind of ridiculous too, because if you have a lady that's like 4'10" and a guy's 6'6", obviously the big guy's going to get a much higher milligram concentration than the little lady. So they didn't bother addressing that, they just ignored it. So I think that set of guidelines is even worse than the ones in 1991. It's a tough question. I don't know the right answer is what I'll tell you.
I don't either. So, so I thought it'd be fun to kind of go over a case. This is an actual case that's of a patient that's been followed here at Henry Ford. So it's a 72-year-old male with a previous diagnosis of asthma. He also has hypertension, arthritis. He's a former tobacco smoker, 10-pack years, quit like 40 years prior to this presentation. But he's presenting to pulmonology clinic as a new patient. He comes in with a 6-month history of chronic cough, daily cough productive of clear sputum, also complains of wheezing and chest tightness throughout the day as well. He's been prescribed albuterol in the past, has received multiple courses of antibiotics for what was called acute bronchitis and the like. A few weeks prior to seeing you, he actually developed worsening symptoms. His primary care doctor gave him some prednisone, azithromycin, for what he called an asthma exacerbation, and it was at that time that he was referred to pulmonology. So he comes in today. He says after he took the prednisone and azithromycin, his symptoms initially improved, felt much better, but now he's returned to his baseline with kind of daily cough, wheezing, and intermittent shortness of breath. He also reports nasal congestion, a lot of postnasal drip. Denies any typical heartburn symptoms, GERD symptoms, but does frequently clear his throat, tests and regurgitation on occasion after large meals. Physical exam's unremarkable. There's no wheezing at that time, no clubbing or really anything else. PFTs were done actually a few months prior to presentation, and they did a pre and post bronchodilator here, but you could see no obstruction and normal airflow there. So what do you do next? You have a new patient that has been prescribed Advair, continues to have symptoms. Any ideas, thoughts? So let's talk about allergic rhinitis. So it's a disorder of the nose induced by an IgE-mediated inflammation after an allergen exposure. Symptoms include rhinorrhea, nasal obstruction, itchy eyes, itchy nose, sneezing, postnasal drip, and then cough. So studies have estimated it affects about 30% of children and adults in the U.S., and in those patients that do have allergic rhinitis, leads to increased healthcare utilization, ER, PCP visits, as well as prescriptions. Clinical diagnosis mostly is based on typical symptoms, response to empiric management, but you can have formal diagnosis if needed. So there's a large systematic review published in the Journal of Asthma in 2006 that went over 12 studies done between 1983 and 2004 to see what the prevalence was between patients who have both asthma and allergic rhinitis. And 12 studies, they found anywhere from 50% to 100% of patients that had asthma had symptoms of allergic rhinitis. They did find that those asthmatics with concurrent allergic rhinitis had high healthcare utilization, as I previously mentioned, which they postulated was a possible marker for more severe asthma. There's been other studies, as we know, that leukotriene inhibitors, such as Singulair that we use for asthma, as well as nasal corticosteroids and antihistamines, all improve allergic rhinitis symptoms and can actually improve the daily asthma symptoms, beta agonist use, and overall quality of life of asthmatics based on questionnaires. So I bring that up because this patient was actually started on Flonase during that clinic visit. He was instructed to continue his Advair and his albuterol inhaler as needed, and you want to see him back in clinic 2 months later. So he comes back to clinic, he reports improvement with his nasal congestion, his postnasal drip. He continues to have this intermittent cough, shortness of breath, and when speaking to him, he reports that his cough is worse when lying flat as well. You repeat his PFTs and put his previous there at the bottom, but you find now you do see a significant airflow obstruction. So now what would you like to do? Nobody's going to answer, so I'll talk about GERD. It's been estimated to be one of the top 3 most common causes of cough. 40% of patients with cough due to GERD are otherwise asymptomatic without what we consider typical symptoms of GERD, such as heartburn, metallic taste in the mouth, or anything else. And studies have shown that it's present in up to 80% of asthma patients. There's a few different proposed mechanisms to why esophageal acid exacerbates bronchoconstriction. I've listed them there. But while we don't know the exact mechanism, we do know that studies have shown that treatment of symptomatic GERD does actually improve asthma outcomes. So I put these studies up here. These are kind of the most frequently quoted studies. So they're all randomized, double-blind, placebo-controlled trials. You can see the number of patients there in each trial. And they're all patients with moderate to severe asthma with reflux symptoms that were randomized to either placebo or a form of a PPI, either lansoprazole or esomeprazole for a variety, at least a few months. So the first study showed no improvement in asthma symptoms, peak expiratory flow FEV1, but did show improvement in quality of life on questionnaire as well as the number of exacerbations. Second study did show a small improvement in quality of life on questionnaire, a little improvement in peak expiratory flows in FEV1, and then the last one did show improved peak expiratory flow only in those with GERD symptoms. So the last study actually involved patients without symptoms of GERD as well. So based on this, we can kind of say that, yes, treatment of symptomatic GERD does improve asthma symptoms. What about asymptomatic GERD? So we know that clinically silent GERD, based on ambulatory pH monitoring and the like, has been identified in about 62% of patients with asthma. So the first study enrolled 412 patients with poorly controlled asthma that they defined as either frequent exacerbations or daily beta agonist use, and minimal to no GERD symptoms. They were randomized to esomeprazole placebo for 24 weeks. They further divided the placebo group and the esomeprazole group into those with and without GERD based on ambulatory pH monitoring. And based on the study, they found that there was no improvement in asthma symptoms or quality of life on questionnaire with treatment, even in those with confirmed GERD on pH monitoring. Another study, 201 patients, again, moderate to severe asthma, no GERD symptoms, and there was no improvement in peak expiratory flows there.
When they treated them for GERD, did they just give them the omeprazole and things of that nature, or did they give them the lifestyle modifications to go along with that?
That's a good question. I actually don't know the answer.
Right, because I see a lot of patients who come to my clinic with asthma when I was just start for it.
Mm-hmm.
And I asked them what treatment was on. I'm on Prozac, I'm on this anthem. What about the other things?
Yeah.
It seemed like they never got them, or they never did them if they did get them.
That's a good question, actually.
So this treatment is incomplete.
That's true.
Well, another point to make too is a number of those studies you're referring to were done by, with ENT evaluations, not pH probes. Looking at the cord, say, to see inflammation, they have GERD. Well, any moron knows anybody's got a cough is going to have inflamed cords on that. So, it depends on how you meet your definition too. So the ones that are pH studies, monitoring, are good studies. The other 2/3 of them are just kind of observational type crap.
Sure. So one question I had when I looked at this was, what's the role in testing in patients maybe with uncontrolled GERD? You suspect they have GERD, or uncontrolled asthma, you suspect would have GERD, but they're not really complaining of symptoms. So based on this, maybe there's no role for testing in patients with asymptomatic GERD to see if they have GERD that's causing their uncontrolled asthma. Place where you would consider testing in patients with GERD symptoms, you start them on PPI, you give them the rest of the 10 Commandments, and then they still have what you can suspect uncontrolled asthma. So you may choose at that point to do pH monitoring to see whether their GERD has actually improved, and if it has, if they're still having symptoms, whether there's something else going on that you're not exactly sure about. Yes.
Did you come across anything about non-acid reflux? I mean, obviously it changes the pH, but what about non-acid reflux? And did you come across anything that looks at asthmatics who perhaps didn't improve with this type of therapy, but who may have undergone fungiplication?
No, I didn't. The only thing I read was that patients, as I mentioned, if they're placed on PPI therapy with no improvement in the amount of reflux on pH monitoring, then an option would be fundoplication. But I didn't go into non-GE reflux. So the patient that you had seen with the drop in PFTs, continued symptoms, he was treated with prednisone course for an exacerbation, and he was started on Prilosec 40 milligrams twice a day during that clinic visit. If you remember, he also complained of worsening shortness of breath while lying flat, so a chest x-ray was obtained at that visit as well. So he comes into clinic 1 month later. At that time, he had an improvement in his cough, but he continued to have shortness of breath on exertion throughout the day and with kind of minimal activity. You repeat his PFTs, and there's an improvement there at that clinic visit. Here's his chest x-ray that you did a month ago, and I'm not sure how well this translates there, but this was read as mild interstitial possible edema in the right lower base, and then some question of cephalization as well. So what to do next? So this leads us into our study. We have cardiac asthma, or cardiogenic pulmonary edema. This leads to pulmonary venous congestion with reflex bronchoconstriction. Can result in wheezing, along as what we see with typical heart failure symptoms, shortness of breath, orthopnea, exercise intolerance. As we all know by seeing these patients, they're not always, the physical exam is not always classic with rales and edema. Spirometry, usually restrictive from my reading with decreased diffusion capacity, but you can also see obstructive airflow obstruction with acute flash pulmonary edema. I don't really have much to say about cardiac asthma except in patients with CHF, make sure you get a BMP, make sure you get an echo, make sure that's controlled. So going back to our case, you get his echo. You have 67%, a little bit of diastolic dysfunction, a little bit of RV dysfunction, elevated PA pressure. An IgE panel was also done at the previous clinic visit to assess whether there's some allergens, some triggers there that is being missed. And as you can see, there's some response to multiple entities there and an elevated total IgE level. So you want to see a patient a month later, but he actually presented to the ER. He went to the ER with left hip pain, radiation to below the knee. He has chronic hip pain, and this worsened when he was out bowling a couple nights before. While he was in the ER, he also mentioned that to the ER physician that he has chronic shortness of breath. He has this productive cough that just doesn't seem to go away. He's found to be mildly hypoxic on room air. He's found to have some wheezing, some peripheral edema. Chest x-ray is done in the ER. It's concerning for possible edema versus infection, so ER gets a CTPE, and this is what they find here. So areas of bronchial wall thickening, mucus plugging there, some bronchiectasis, and then this is lower down, some ground glass opacities. Probably can't see the tree and bud opacities peripherally as well. So the ER gives them Rocephin, azithromycin, gives them a dose of Lasix, and admits them for possible pneumonia. So after he's on the GPU, pulmonology is consulted, concerned for ILD. On examination, he's found to have a petechial rash on his lower extremities. And as well as, along with the total IgE that you know to be elevated previously, CBC shows 70% eosinophils with an elevated absolute count. So hematologists consulted for concern of a hypereosinophilic syndrome. They recommend a serological workup that's largely negative, negative ANA, ANCA, lupus. Does have a mildly elevated or elevated RF and serum IgA. So at that point, they think the eosinophilia is likely secondary to just asthma and its significant allergies, and they didn't recommend an extensive workup for eosinophilia at that time. So based on kind of the chart review that I went over and looking at the notes, the main differential diagnosis that was documented was, again, a hypereosinophilic syndrome, chronic eosinophilic pneumonia, parasitic infection, or severe asthma. So a bronch was recommended. So an attempt to kind of shoehorn asthma mimickers into this presentation. So things that we can find on bronchoscopy and laryngoscopy. Tracheobronchomalacia is one of them. So that's a weakness of the trachea, or in the case of tracheobronchomalacia, the bronchioles as well, due to atrophy of the elastic fibers or impaired cartilage integrity. This leads to a dynamic collapse of the trachea during expiration that's more pronounced than what we see in the normal population. There is some collapse of the trachea normally. And this occurs in about 5 to 10% of the general population that are asymptomatic. As we've seen in the past, most commonly due to prolonged or recurrent mechanical ventilation. It can also result from high cuff pressures causing localized injury, prolonged external pressure on the tracheal wall from a malignancy or a goiter or some congenital vascular defect, as well as some other things. So common symptoms of this: shortness of breath, cough, wheezing, sputum retention. As you can see, very similar to asthma. A lot of patients that have this can be asymptomatic and only symptomatic when they have an infection or pneumonia that can cause us some secretions building up that can further collapse the trachea. One thing I came across in my reading is suspect in patients who fail extubation trials unexpectedly. If you have someone that comes in for presumed asthma exacerbation, they're intubated, they're doing well, you extubate them and then they fail, the CPAP can obviously splint open the airways, so when you take away that positive pressure, they have some difficulty, so something to keep in mind. So this was a study that was performed to see if there was any association between tracheobronchomalacia and then as well as dynamic airway collapse in those with asthma. So they took 202 asthmatic patients and compared them to 62 patients who had no obstruction. Again, this is based on FEV1 spirometry, so maybe not the best method. But they did find a much higher proportion of not only tracheomalacia, but dynamic airway collapse in patients with asthma. They also found that patients with more severe asthma had a higher proportion of tracheobronchomalacia and excessive dynamic airway collapse. Previous studies have shown that patients with COPD and former smokers can have tracheomalacia, so it's possible that the chronic inflammation of the smoking and the COPD can lead to destruction of the tracheal fibers and the tracheal wall. So the thought here was that the chronic inflammation and the stress from coughing or high peak airway pressures due to air trapping can lead to the weakness of the elastic fibers. So diagnosis, primarily made through bronchoscopy. It's characterized as mild, moderate, severe based on the percentage of narrowing. You can see there would be a severe tracheomalacia as there's contact between the anterior and posterior walls. Dynamic CT is also a modality that can be used to diagnose this. It's not standard of therapy at all, but it would be something if a patient was unable to undergo bronchoscopy, as it is an invasive method can do. You can see there the middle picture is with end expiration. It might be within normal variance, but when the patient has a forced expiration there in C, you can see some collapse.
I make an observation. Everyone talks about tracheobronchomalacia as if that was a problem with the tracheal cartilages. If you look at the CT scans that you usually see, and if you look at that CT scan, there's no deformation of the anterior wall of the trachea. What's happening is that the muscularis, the posterior tracheal wall, is opposing the anterior tracheal wall, right? And that's something that happens normally in a cough. Mm-hmm. And I would suggest that many of these patients with asthma or COPD who have large swings in their pleural pressures are having this kind of a process, not because there's anything wrong with their trachea, but because of the basic pathophysiology of lung compliance and airway compliance in asthma and COPD, and that these findings may not have anything to do with some intrinsic problem with the trachea.
Yeah, that's something I came across.
I agree with you on that, Dan. I feel the same way.
Yeah, is that it was found that a large proportion of healthy subjects actually had similar findings, as you mentioned. So there was some question about whether 50% collapse really should be considered
I think
pathologic
the
or not.
diagnosis is really a grab bag diagnosis with lots of different things and not just one thing that means the same thing all the time.
So as far as PFTs, there was a study published in Respiratory Care in 2013 that tried to see whether there were any characteristic findings in patients with tracheomalacia. So this was a retrospective analysis of 90 patients that were diagnosed with symptomatic tracheobronchomalacia on bronchoscopy with the typical symptoms who had PFTs obtained during their initial evaluation. They all had moderate to severe, so greater than 75% narrowing without any previous airway interventions such as tracheostomy or stenting or anything else. A large proportion of the patients, as we're kind of discussing, do have concurrent disease, COPD, asthma, OSA, or the like, and that was something they mentioned. As far as spirometry, 44% of them had evidence of an obstructive defect, 18 restrictive, 17 were mixed, and 21% had normal spirometry. So these authors concluded that spirometry isn't really characteristic of tracheomalacia and can't really be used to make the diagnosis. With flow volume loops, they did find that 82% of these patients had low peak expiratory flow. 17% had no abnormality, and then you can see these numbers on top. This obviously adds up to more than 100%, and that's because a lot of the patients with the morphology that I'll discuss in a sec also had peak expiratory flows. But they also concluded flow volume loops, while there's a few different morphologies that are seen, aren't really reliable in making the diagnosis. But as you can see, the first one's biphasic, so a sharp peak and then a rapid decline followed by a plateau phase. You could have notched expiration there, and then the third one is oscillations, what they call the sawtooth pattern, with frequent oscillations or accelerations and decelerations with expiration. I won't really get into the treatments, but you really want to prevent bronchospasm, advanced interventions or stenting, tracheostomy, tracheoplasty. Another common asthma mimicker is vocal cord dysfunction. I just saw this for the first time in the ICU like last week, but it's describes an abnormal adduction of the vocal cords during breathing, usually inspiration, producing an airflow obstruction. Most common symptom is shortness of breath. You can also see some wheezing, some stridor, cough, and chest tightness. You can see why it would be thought to be asthma. Occasionally they can have some neck pain, hoarseness, dysphonia, some throat tightness that can clue you in that this is something going on in the upper airway rather than going on in the lungs. The exact mechanism isn't exactly known. We do know there's a large psychosomatic component. A lot of these patients have psychiatric disorders, bipolar disorder, depression, childhood traumas, and symptoms can actually be triggered by severe emotional distresses. Some non-psychologic causes that have been thought to be are GERD, some neurological diseases. Triggers are similar to asthma, dust, smoke, exercise, irritants. It's also been shown to be either occurring alone or concurrent with asthma. A retrospective analysis of almost 300 patients at an asthma and allergy clinic that were diagnosed with vocal cord dysfunction. Of those patients, 42% of them were found to be misdiagnosed with asthma for an average of 9 years. Almost a third of these patients also had asthma. Between the groups that had vocal cord dysfunction and asthma, there was no real difference in asthma severity for their criteria. Another study was a prospective evaluation of 167 patients with intractable asthma that went into evaluation to see what the cause of the refractory asthma was, and they found that 30% of cases that were felt to be treatment failure of asthma actually had vocal cord dysfunction. 1/3 of those patients only had vocal cord dysfunction, and 2/3 of them had it along with asthma. So these are the typical clinical manifestations. You can see vocal cord dysfunction is a little bit more hyperacute. Lasts seconds, more with inspiration versus expiration for asthma. You can localize to the neck. Drugs are obviously ineffective, and similar triggers and cough characteristic. As far as diagnosis, I put this under bronchoscopy, but it would be really under laryngoscopy. But when evaluating vocal cords, you see the characteristic posterior, what they call chinking there, during expiration. As far as full volume loops, I think we've all seen this image, even during residency on boards and things like that, but you have the flat inspiratory curve that's characteristic of a variable extrathoracic obstruction. There's also something called the vocal cord index. I won't spend a lot of time on this, but basically it's a weighted scoring index that helps distinguish vocal cord dysfunction from asthma. Compared to 89 vocal cord dysfunction patients with 59 asthma patients. And they defined 4 key distinguishing symptoms: throat tightness, dysphonia, absence of wheezing, and trigger of symptoms with odors. And was felt to have a good positive predictive value for vocal cord dysfunction. They validated the scoring system within the study on 72 patients with proven vocal cord dysfunction, and it accurately diagnosed it in 78% of patients. As far as therapy goes, the mainstay of therapy is speech therapy, vocal cord relaxation techniques, breathing exercises, and then underlying psychiatric treatment. And then in the acute setting, you can use Heliox, Botox, lidocaine as well. So getting back to our patient, he underwent his bronchoscopy, found to have mobile, non-edematous vocal cords. Airway exam showed some mild airway edema in the right lower lobe, and he had a right middle lobe BAL, right lower lobe transbronchial biopsy done. BAL results, you can see high amount of WBCs with 96% eosinophils. So while he's inpatient, shortly after he got his bronchoscopy, he developed a new left foot weakness. He did have a history of previous neuropathic pain, but this was the first time he had any weakness in the foot. Neurology was consulted and EMG was done that showed a chronic radiculopathy of L5-S1 with some S1 denervation. Around the same time, a skin biopsy was performed of the petechial rash that showed a leukocytoclastic vasculitis without any vessel involvement. Did not suggest Church-Strauss. Lung biopsy results returned, showed a benign inflamed lung, negative for infection, and pulmonary vessels negative for vasculitis. So at this point, there was some concern for an underlying vasculitic component or rheumatological components, but they weren't sure what, so they consulted neurosurgery for a nerve and muscle biopsy. So what do we know? We have a 73-year-old male at this time with a history of asthma, chronic rhinosinusitis, allergies. He has elevated eosinophils, IgE, negative ANCA, ANA, other serologies. He has lower lung glass opacities with bronchial wall thickening, septal thickening. Lung biopsy is inconsistent with vasculitis. He has a leukocytoclastic vasculitis and a neuropathy. Any ideas or thoughts? Church-Strauss? Jesse, you're cheating. So let's talk about Church-Strauss for a minute here. It's a systemic necrotizing vasculitis. Affects small to medium vessels associated with severe asthma, serum and tissue eosinophilia. It's about 10 to 13 cases per million with an incidence of less than 1 to about 7 cases. There's 3 distinct phases of disease. The prodromal phase is the first, pops up in the 20s to 30s, characterized by allergies, rhinosinusitis, asthma, followed by the eosinophilic phase, which is when you start to see the blood eosinophilia, infiltration of multiple organs with eosinophils, and the vasculitic phase. 40% of patients before they progress to the vasculitic phase may present with pulmonary opacities, asthma, and a peripheral eosinophilia. Pulmonary manifestations, so asthma is the cardinal feature of Church-Strauss, present in up to, some studies show over 90% of patients, and usually precedes the vasculitic phase by 8 to 10 years. So you really want to suspect this in patients with poorly controlled asthma on adequate therapy that receive moderate doses of steroids, which can be difficult because prolonged or frequent steroid courses has been shown to suppress clinical signs, other clinical signs of Church-Strauss, which may clue you in on the disease. It's a multi-system disorder. Lung is the most commonly involved. Up to 70% of patients can have, along with asthma, pulmonary opacities, effusion, nodules, hemorrhage. This is the prevalence of organ involvement. You can see asthma is up to 100%, followed by ear, nose, and throat, neuropathy, pulmonary involvement. Church-Strauss is grouped in the ANCA-associated vasculitides, but you can see that based on the studies I looked at, anywhere from 30 to 40 to 70% of patients are ANCA positive, and of those, we know that P-ANCA is the more common. So these don't show up too well, but on the left you can see a chest X-ray with pulmonary opacities. On the right, a CT scan with some mucus plugging. Other manifestations I mentioned: upper airway and ear, rhinitis, nasal obstruction. Skin, up to 2/3 of patients. You can have anything from subcutaneous nodules to petechiae, purpura. Cardiovascular is the most common cause of death. Causes death in 50% of these patients from pericarditis, myocarditis, heart failure, arrhythmias. In neurology, there's a neuropathy in up to 75% of patients. So for diagnosis, the American College of Rheumatology came out with some guidelines requiring at least 4 of the following. So you must have asthma, greater than 10% eosinophils, a mononeuropathy, pulmonary opacities, sinus abnormality, or a biopsy with vasculitis, and that shows extravascular eosinophils. The Lanham criteria is a little older. For me, this was kind of one to clue in on Church-Strauss, so you need all 3, asthma, eosinophilia, and then evidence of systemic vasculitis. As I mentioned earlier, it's an ANCA-associated vasculitis, but is not seen in all patients. So the asthma in Church-Strauss is typically severe, requires maintenance steroids even after remission of systemic disease. So asthma exacerbations occur independently of the systemic vasculitis, don't reflect a level of activity. So they might be treated with immunosuppression that may control their systemic vasculitis, but they may still have uncontrolled asthma. One thing I wanted to mention was that actually leukotriene receptor agonists were previously thought to cause asthma, but now are considered to safe to use for use in asthma, and those with Church-Strauss. As far as the airflow obstruction, as I mentioned, it's severe. There was a study done in Allergy in 2009 that showed airflow obstruction was found in 70% of patients at diagnosis. They did have improvements with treatment up to 6 to 12 months, but in 3 years, 40% of them still had airflow obstruction. And obviously a lot of these patients were on long-term oral steroids. As far as the prognosis, there's a 5-factor score that came out in 1996 that found that age over 65, cardiac, renal, GI involvement, or no ENT involvement came with a worse prognosis. And the scoring system was, if you had none of these, you had a 12% mortality, 1, 26, and 2 plus 46. But since this has come out, it's been revisited in 2011, I believe. They kind of took out the age components. And overall, patients with Church-Strauss now have an improved mortality based on what we understand of the disease and better treatment. So steroids are the mainstay of therapy. You want to start with a high dose, obviously, followed by a taper. You can use Cytoxan and then methotrexate and azathioprine as well for maintenance therapy. Talking real quick about ABPA, which is also in the differential. It's a hypersensitivity colonization with Aspergillosis. It occurs exclusively in those with asthma or CF. Presents as uncontrolled asthma, recurrent exacerbations, brown, black sputum production, hemoptysis, possibly pulmonary opacities, found in up to 5% of asthmatics. It's a typical CT scan here. You can see bronchiectasis, mucus plugging, pulmonary opacities. Labs, what to expect with ABPA: elevated serum eosinophils, elevated IgE, that improves with steroids, and you diagnose with skin sensitivity testing, IgE antibodies, or positive sputum culture. PFTs can show the typical airflow obstruction you do see with asthma. The actual diagnostic criteria, patients, there have been a few case reports of ABPA occurring in those without asthma or CF, but for the most part, asthma or CF, either skin test or IgE positivity and elevated IgE, and then 2 of the 3 of precipitating serum antibodies, pulmonary opacities, or an elevated eosinophil counts. As far as treatment, steroids and antifungals are the mainstay of therapy, and while omalizumab is an IgE antagonist, is not currently recommended for therapy. So going back to our patient, so he had a nerve biopsy done that did show an inflammatory inflammation dominant by eosinophils around the small arteries that was suggestive of Church-Strauss. Left quadricep biopsy found no vasculitis. So the patient's 5-factor score was 0. Again, age was taken out. So rheumatology recommended discharge the patient on prednisone, 1 mg per kg per day. He went over a 2-month taper. His inhalers were discontinued. He followed up in Pulm Clinic, I think yesterday actually, when I was going over the charts, and his respiratory symptoms have resolved. His neuropathy's continued, but he's continued on his prednisone taper, and he'll continue to follow up with both Pulm and rheumatology. So in summary, asthma is a heterogeneous disease, variable clinical features and phenotypes, so obviously a large differential. Just as always with any patient, obtain a good history and physical. Keep in mind other etiologies that may either masquerade as worsening asthma or asthma when there is none. That's all. Those are my references. Thank you. Questions?